Dr. Rupal Shah was talking to us about the complications. Now, though Smile has been available commercially for about 10 years, Dr. Rupal Shah, I guess, has been working on Smile for almost 15 years. She's the person who has actually done all the work for Zeiss on perfecting the Smile platform. Almost 15 years back, she started. All the ways that the cuts are being made and the energy settings for the cuts were all designed by Dr. Rupal Shah. So it's very, very gratifying to have you here. Talk to us about complications.
Thank you, Dr. Varman, and thank you for inviting me to be a part of this really comprehensive and good Smile session. What I'm going to be talking about is complications and management. As Dr. Ramya already pointed out, it's a simple procedure. If you do it well, it does not really cause any complications, but every procedure do have their own set of complications, and if you know them, if you anticipate them, then you can also handle them well. And cornea, as you know, is a very forgiving part of the eye, and so if you manage your complications well, then there is absolutely no damage to the patient done. I am a consultant for Carl Zeiss. I do receive travel and research grant. So there is actually not complications with Smile. I would tell them as special situations. Retreatment after Smile is something that I think Dr. Ramya didn't touch upon, and I will just throw a little light on that, because complication can also be in the form of under or over correction and not the final desired outcome that a person has wished. Most times, complications are related to intraoperatively, and the commonest one is suction loss during the several femtosecond laser passes, and sometimes a lenticule getting stuck under the cap. So we'll just deal with those little in detail. As regards retreatments, we know that LASIK retreatments are simple. If it's in the early stage, you can just lift the flap and perform the excimer laser if you know how much is the bed and the flap quality. Some people prefer to make a new deeper cut, and also sometimes you can just make a side cut with a femtosecond laser and open the same flap or go on the surface. In Smile, we don't have the luxury of a flap, so we cannot relift it, and therefore what we need to do is do a surface ablation for doing a retreatment. But we also have a very good alternative in terms of a circle software, which can convert the cap into a flap, and then you can open it and run the excimer laser on the bed. This is important because if you just go ahead and do a surface ablation, then sometimes there is, the patient of course has more pain, greater recovery time, and they had wanted to avoid this in the first instance itself. Also, there are more chances of haze if you don't use mitomycin C along with when you are doing a retreatment with surface ablation over a flap or a cap. So it does become a little more complicated in that sense. And therefore, the circle software, which is a really nice and elegant way of converting the cap into a flap, is something that can be used. It's not as simple as you would think, because to get the same plane would require a lot of thought upon, and this is how it was devised. So the first studies on animal eyes were done within the Singapore Eye Institute, and this is the first circle software used in the world on a patient. So I would like to show you this, because right from the first cut itself, we could approach the same plane and do a treatment. And today I must have done about 40-45 uses of circle cuts, and every single time I could get to the same plane. What it does is, as you saw, it created a round of extra femtopulses beyond the Smile lenticule, and therefore it gives you enough space even to correct a hyperopic overcorrection. And you can see I'm being very tentative here, because I was not sure whether I would be in the same plane, but to our great surprise and pleasure, it was very easy to open the flap. and to get the same plane to finish the treatment. So you could use this. Uses of circle after that have been many folds, but before that I would talk to you about the different stages at which you can get a suction loss while doing the procedure and what to do about it. So as you know, as has been really nicely described by Dr. Ramya, smile has various cuts. The first cut is on the posterior plane. This is followed by a side cut. This is immediately followed by an anterior cut, and finally it ends as a small incision. So there are 4 femto cuts, and the suction loss can happen at any of these 4 places. So if you get a suction loss when you've just started doing the procedure, if it happens within the first 10 to 20 microns, then there is no problem, 10 to 20 seconds, and it has just started and you get a suction loss, then there is no problem. You can just go ahead and do it as a smile procedure. But if it happens like this, where you have already done the first pass and not finished the side cut, then the company recommends that you should not do it as a smile procedure, but gives you an option to do it as a flap. Because the first pass is very important. It is giving you the refractive result. So if you go ahead and do a smile cut again, it may not go to the same plane, and then you would not want to have under or over correction. So you can convert it into just a flap and do it as a femto LASIK, as I've shown here. You do have this choice of going to whatever depth you want, however big you want. So just like you would do your normal flap creation, that's the way you do it. You should remember that the first pass is much posterior, and therefore your flap is going to be much anterior, and it would not really coincide with that plane at all. Coming to the next place where you get it after the side cut of the lenticule is made, and there are telltale signs. As you can see, there are some water molecules already on the suction, on the cone, the contact glass, and you can see the patient has started moving. At that particular time, you should try and tell the patient to calm down and to go ahead, but sometimes the patient is too nervous and starts fidgeting, and you can get a suction loss right at the end. Now, if you get it at the after the side cut of the lenticule is done, you could just go ahead and refit the contact glass like was shown here, and you'll find that you can approach the plane very easily. All these cases are the first 500 cases done in the world, and we didn't know exactly what to expect, and yet we've gone ahead and done this to know whether you get the same plane or not. But we had done a few femto flaps with the laser, and we did know that you can actually go to the same plane. This can happen if you go immediately. Use the same contact glass, because the contact glass leaves a footprint. So if you just go ahead and fit it again, then the footprint gives the contact glass now goes and fits into the same place. So you get the same centration. Also, if the pass has already started, it's the plane of least resistance, and therefore the next pass is going to go exactly in the same plane. I had done in a femto flap 3 times docking, because I got suction loss 3 times, and to my utter surprise, I had actually got the same plane. You can sometimes have the whole procedure done, and finally you have about the procedure getting aborted at the final incision. It's very frustrating, because you would feel that, oh, you've just gone and touched the other end, but you have not finished the race yet, and you can have a suction loss like this. Now, if that happens, there is absolutely nothing to worry about. Your bubbles are still there to guide you, and you can use the infrared camera and know that your suction is correct, the centration is correct. You can see here I'm adjusting, making the patient look wherever, and then fixing the suction ring. And after that, it just creates a small incision through which you can approach the planes that you have done. So suction loss is not really a very big problem if you handle it properly. You should not get perturbed. Calm down your patient. Use the same contact glass. Make sure that you have the same centration, and you would not have any problems in the final outcome. So that's the take-home message. Sometimes it can be not such a rosy picture, and this is one such case where again we aborted the case at the final incision. Patient was very, very anxious. She was moving a lot. You can see right from the first pass that water is seeping into the suction glass, and just at the last moment we got a suction loss. Now here you can see there is a lot of thick bubble layer in the center, which is not allowing us to really have a look where we are exactly centering. So we tried. Patient was also not able to look straight ahead. She could not. She was very anxious. And we still tried to get the correct centration. You can see dense bubble in the center, so we could not actually make out where exactly that green point was. And all the other bubble on the periphery was not there. So we did get a incision, but the incision was not connected to the plane inside. So we tried opening the incision, but we could not go and approach the plane. At this moment, rather than trying to make false passages, I would urge you just to leave it alone, or to go ahead and do another incision little more inside. Here what we did was, this was our very initial time, we didn't have many experiences, so we just left this alone, didn't approach the area, and went ahead and did a surface ablation after the original edema subsided. So you should use the correct technique, and you should use your brains to decide whether you should want to go ahead or not, and not just try desperately to finish the procedure, because ultimately for the patient it's the result which matters. And so you should not really compromise in any corneal refractive surgery, and just in order to finish the procedure. I'll just take one more minute. Sometimes you have lenticules stuck under the flap, and that can create a problem. But Dr. Ramya very nicely showed how you can remove it. You also have rescue instruments like this, which can help you to, like a rake, which you use to remove the leaves from the ground. You can actually separate the lenticule and remove it by finding the plane on the other side if it's not close to your incision site. Other complications has been pointed out. You can have lenticule tags remaining behind. You can have materials like eyelashes, fiber, foreign body, mucus in the contact glass cornea interface. If you find that on docking, there are areas where we are finding these things stuck under the contact glass, you should just stop the suction, clean the whole surface, clean your eye, dry it, and then redock. If you need to, then just change the contact glass, but don't go ahead with a dirty one, because that would lead to a lot of black spots, and it would lead to a very difficult separation. Post-operatively, sometimes you can have fine interface haze, and here there is a big role of steroids. You can just give potent steroid, so something like a prednisolone acetate eye drops, given in a higher dose for a short period, and this will clear the slight haze. Sometimes there is persistent dry eyes, especially if the person is a chronic contact lens user and already had dry eyes, and it should be treated as such. And even though you are actually leaving the cornea much stronger, there have been cases reported of ectasias happening even after smile. So you should be very careful and not really go and delve into this gray area of having form-fristic keratoconus, thinking that it's still safe to do this because you are not creating a flap. Thank you very much.
Thank you, Dr. RUPAL SHAH. Of course, in any procedure, the potential complications can be varied and the approach to correct each one of them can be different. So we've covered the most common complications. Trust me, if you're a meticulous surgeon following all the protocols, you probably won't see any of these. Now, RUPAL SHAH has seen everything because she started very early and she had machines that were completely, if you look at it, were dinosaurs compared to machines of today. So none of these you're going to see, so don't get worried looking at these complications.